Hello, this is Miss Walton. Today we will be looking at the child with alterations in cardiovascular function. The majority of cardiac illnesses seen in children are related to either congenital cardiac deficits or to an inflammatory process. So let's get started. When we talk about fetal circulation, the ductus venous is a fetal blood vessel that allows for blood to bypass the liver. The foramen oval is the opening in the septum between the two atria. This permits the portion of blood to flow from the right atrium directly to the left atrium. The ductus arteriosus provides a connection between the pulmonary artery and the aorta that allows blood to flow from the pulmonary artery to the aorta and bypass the fetal lungs. So this is all happening during fetal circulation. If you want to pause the video, there is a fetal circulation video on YouTube that you can watch. For you visual learners, here is a diagram of fetal circulation. Changes that happen at birth. You have the systemic vascular resistance that increases after the umbilical cord is cut. So that's when the closure of the foramen oval happens. The ductus arteriosus closes at about 10 to 15 hours after birth. And then the ductus venous becomes a ligament after birth as well. And then the right ventricle is larger than the left at birth. And the pulmonary resistance will drop and systemic resistance will increase. So with that first breath, there's going to be some changes in pressure. The pulmonary alveoli open up, the pressure in the pulmonary tissue decreases, blood from the right side of the heart rushes to fill the capillaries and alveoli, pressure on the right side of the heart decreases, pressure in the left heart will increase, and then you have the pressure in the aorta, which increases as well. Some cardiac pediatric differences that we see are going to be cardiac functioning and oxygenation. So let's start with cardiac function. The infant's metabolic rate and oxygen requirements double at birth, so the heart rate is high to maintain high cardiac output and adequate oxygen transportation. Infants are at a greater risk of heart failure than older children because of the immature heart. It's more sensitive to volume and pressure overload. The cardiac output in newborns and young children also depends on the heart rate until the heart muscle is fully developed, and that happens around 5 years of age. So when we look at differences in oxygenation, you have desaturated blood that results when oxygen and unoxygenated blood mix because of congenital heart defects. You will see cyanosis in neonates when the saturations drop below 79%. And then keep in mind that bone marrow responds to chronic hypoxemia by producing more red blood cells to increase the amount of hemoglobin available for oxygenation. So for a child with a cyanotic heart defect, it's going to be about 50% or higher. So do you guys remember what that's called? Polycythemia. That shows the anatomy of the heart, just as a refresher. Let's talk about congenital heart deficits. So this is going to happen when there's an anatomical deficit of the heart that prevents normal blood flow to the pulmonary and or systemic system. So let's talk a little bit about etiology. So why does this happen? Some things like fetal exposure to drugs. So some of those drugs could be phenytonin, lithium, alcohol, and tobacco. You also have maternal viral infections such as rubella and cytomegalovirus, and then maternal metabolic disorders such as diabetes and lupus. And then you also have to keep in mind that an increased maternal age can affect this as well. So, you have increased changes of chromosomal abnormalities after 35 to 40 years of age of the mother. You've also got genetic factors and chromosomal abnormalities such as Down syndrome, Turner syndrome, missing X chromosome, webbed neck, infertility, and constriction of the aorta. So, keep in mind some risk factors are going to be a murmur at birth, early infancy, hypertension, feeding difficulty. With that, you'll see shortness of breath or easily fatigued, diaphoresis, poor intake, cyanosis, tachypnea, deviation of normal growth and development, and they're unable to keep up with their peers. So you see that decreased activity level. And then some children also have frequent respiratory infections. A little bit about congenital heart deficits as far as pathophysiology and hemodynamics. So with the acyanotic congenital heart deficit, you have that left to right shunt that leads to heart failure. The blood enters and re-enters the pulmonary system. So that can be caused by an atrium septal defect, a ventral septal defect, patent ductus arteriosus, and atrioventricular canal. So then when we look at the cyanotic deficits, you have that right to left shunt that leads to hypoxemia. So the blood bypasses the pulmonary system. In other cyanotic defects, the deoxygenated blood never reaches the pulmonary system. And then you also can see that transposition of the great vessels and tetralogy of Fallot. So with obstructive congenital heart deficits, that can lead to a decrease in that cardiac output, and it prevents the free flow of blood through the heart. Some things like tricuspid atresia, pulmonic stenosis, aortic stenosis, and coarculation of the aorta is seen. So when we talk about mixed congenital heart deficits, this is where there's a mixing of systemic and pulmonary blood flow. So you have deoxygenated and oxygenated blood flow that's mixed. You also will see this with the transposition of the great vessels. So we're going to talk a little bit more about all of these deficits going forward. Acyanotic heart deficits. With acyanotic heart deficits, you will see that left to right shunt. So pressures on the left side of the heart are normally higher than pressures on the right side of the heart. If there's an abnormal opening in the septum between the right and left sides, blood will flow from the left to the right. So as far as pathophysiology, there's a connection between the right and the left side of the heart, which increases the amount of blood pumped to the lungs. The increased pulmonary vascular resistance is created, leading to pulmonary hypertension and right ventricular hypertrophy. Eventually, this can lead to congestive heart failure if it's not treated. Do you guys remember the signs and symptoms of congestive heart failure? With that, you will see crackles in the lungs, wheezes, cough, dyspnea, tachypnea, tachycardia, weight gain, diaphoresis during feeding difficulties. So, when we talk about feeding difficulties, that's going to be shortness of breath, they're easily fatigued. So you should be catching this early on when the child is an infant. Take a look at this diagram that shows the blood flow with acyanotic heart deficits. Acyanotic heart deficits are those left to right shunts. So when we talk about patent ductus arteriosus, that is where there's a failure of the ductus arteriosus to close. With atrial septal deficits, that is going to be an abnormal opening in the atrium. With ventricular septal deficits, you're going to have an abnormal opening in where? The ventricular area. The ventricles. With atrioventricular canal, you will have an incomplete fusion of the endocardial cushions. So this is very common in Down syndrome. So there's no septum and just one large valve. Acyanotic heart deficit, again, that's that left to right shunt. So some clinical manifestations that you will see is the infant is not going to be cyanotic. Again, that acyanotic heart deficit. So remember that. They may have a murmur, tachycardia, tachypnea, poor weight gain, cardiomegaly due to increased workload. What's cardiomegaly? Increased size of the heart muscle. They tire very easily while they're eating and they become diaphoretic. There's an increased number of respiratory infections due to blood pooling in the lungs and promoting bacterial growth. And then congestive heart failure can develop. What do you see with that? Dyspnea, tachypnea, intercostal retractions, wheezing, grunting, edema, cardiomegaly, hepatomegaly, distended neck veins, and possible weight gain. What is that possible weight gain from? Edema. Let's talk about acyanotic heart deficits a little more in depth. With patent ductus arteriosus, the incidence is about 10%. It's one of the most common benign deficits. The ductus normally closes within hours of birth. So keep in mind that there's a connection between the pulmonary artery. So you have low pressure and the aorta has high pressure. So there's a risk for pulmonary tension and congestive heart failure with this. The ductus arteriosus is a blood vessel that's present in all babies in the womb that allows blood to bypass the pathway to the lungs. When the cord is cut, the lungs fill, changing the pressure of the chest, and the ductus arteriosus should close in the first few hours of life. So when this doesn't, that is when we have a patent or open ductus arteriosus. It's more often seen in premature babies, but can also be seen in babies that are full term. Have a little anatomy review. You can see number one, this will be the patent ductus arteriosus. So this is the ductus arteriosus, and this, what happens is this does not close. So how do we diagnose and treat patent ductus arteriosus? It's diagnosed by a chest x-ray. You'll see an enlarged heart and dilated pulmonary arteries. They can also do an echocardiogram, and that's going to show the opening between the pulmonary artery and the aorta. You'll see a machine-like murmur with bounding pulses. Keep in mind the echocardiogram uses sound waves to show how blood flows through the heart and heart valves. So you'll see enlarged chambers from more blood flow. So keep in mind to have extra blood flow with this. Okay, how is patent ductus arteriosus treated? There is an indomethacin given PO. It constricts the muscle in the wall of the patent ductus arteriosus and promotes that closure. You also may have a cardiac catheterization with a coil that's placed in the opening duct, and it kind of acts like a plug, and then closed heart surgery where there's a small incision made between the ribs on the left hand side and the PDA is ligated or tied and cut. Keep in mind with NSAID, kidney injury or bleeds are side effects from that. And then, this issue can still close on its own. It just may need some time. So oftentimes they may wait depending on the severity to see if it closes on its own. All right, let's take a look at this question. The nurse is educating the parents of a child with a ventricular septal deficit regarding the child's condition. Which of the following information would be appropriate for the nurse to provide? Pause, think about it, then unpause, and I'll give you the answer. The answer is C. The baby's heart is working harder than a normal heart because some of its blood is re-entering the pulmonary system. Now let's move on to cyanotic heart deficits. Cyanotic, what do you think that means? You're going to see that the child is cyanotic with these, correct? So this is going to be a right to left shunt. With cyanotic heart deficits, again, you have that right to left shunt. This is going to occur when the pressure on the right side of the heart is greater than the left side of the heart. You have the resistance of the lungs in abnormally high, and that's going to cause an increase in your pulmonary pressure. And then your pulmonary artery is restricted. That's called pulmonary stenosis. As far as pathophysiology, you'll see that deoxygenated blood from the right side of the heart shunts to the left side of the heart and out into the body. The deoxygenated blood from the right side shunts to the left side and out to the body. And this can lead to hypoxemia. Cyanotic heart deficits, right to left shunting. With this, you have the pulmonary blood flow that is decreased. So you can have pulmonary stenosis, which is a narrowing of the pulmonary valve or artery that results in an obstruction of blood from the ventricles. With tetralogy of Fallot, or Fallot, there are 4 deficits seen with this. You have a ventricular septal defect, pulmonary stenosis, an overriding aorta, and a right ventricular hypertrophy. Then you can also have pulmonary or tricuspid atresia. With this, that is where the failure of the tricuspid valve, there's a failure of the tricuspid valve to develop. Some clinical manifestations with this right to left shunting that you will see are hypoxemia, cyanosis, poor weight gain, tachypnea, dyspnea, clubbing. Do you remember what clubbing is? Polycythemia, that is an increase in your red blood cell production due to the body's attempt to compensate for that hypoxemia, and hypercyanotic spells or TET spells. We're going to talk a lot about TET spells, and you're going to see this in the future as well. So keep in mind that the deficits allow little to no blood to reach the lungs to get oxygenated. The bone marrow is stimulated to produce more red blood cells to increase hemoglobin so that oxygen can be carried. Polycythemia is an above normal increase in the number of red blood cells and can place the child at risk for what? Thromboembolisms. Over time, platelet survival is reduced and clotting factors are impaired. So what happens? This increases the infant's risk of bleeding with surgery. What's a TET spell? A TET spell can be associated with a sudden increase in cardiac output by use of oxygen from crying. So oftentimes, when they've been crying or feeding or playing or exercising or straining with defecation, they will have these TET spells. And this causes them to turn blue. A little later on, we're going to talk about what to do with these TET spells. When children have hypercyanotic episodes, we need to know how to manage them. We often call them TET spells. So they may also be able to give propanol to prevent a hypoxic event. And keep in mind, if these TET spells are not treated, this can lead to syncope, seizure, stroke, and death. So how do we want to manage these hypertonic episodes or TET spells? We want to place the infant in a knee-chest position. Why? Because this reduces blood return to the legs and kind of just forces it to the heart. We want to reduce any painful stimuli and calm the child down. Administer 100% oxygen. Administer morphine sulfate. That can be more aggressive. You can also get ketamine, sodium bicarb to treat any acidosis or a vasoconstrictor. You also want to administer fluids intravenously and keep that hematocrit and blood viscosity within acceptable limits, and then document the occurrence, actions taken, and the infant's response. So let's take a look at what the knee-chest position looks like in infants and toddlers. You have one picture with a nurse putting the child in an infant knee chest position. And then you also see a child that has a cyanotic heart disease deficit. See how they're kind of squatting? They have that knee chest position, and that helps to relieve those spells. What do we often call these? TET spells. Let's move on and look at some types of cyanotic heart deficits. Let's talk about tetralogy of Fallot, or Fallot, depends on how you pronounce it. This composes of 6% of deficits. It is the most common cardiac malformation responsible for cyanosis in a child over the age of 1 year. With tetralogy of Fallot, you will see a narrowing of the pulmonary valve, a thickening of the wall of the right ventricle, displacement of the aorta over the ventricle septal deficit, and ventricular septal deficit. You'll have that as well. And remember, that's an opening between the left and the right ventricles. So this is 4 abnormalities that result in insufficiently oxygenated blood being pumped to the body. So again, to recap, there's 4 components. You have that ventricular septal deficit, pulmonary stenosis, where you have that narrowing of the pulmonary valve. You have the overriding aorta, that's the aortic valve, is enlarged and appears to arise from both the left and right ventricles instead of the left ventricle. And then you have the hypertrophy of the right ventricle. That's that thickening of the muscle walls because the right ventricle is pumping at a higher pressure. What are some clinical manifestations with tetralogy of Fallot? So it's going to depend on the degree of the right ventricle outflow obstruction. You will also see a right to left shunt, clubbing of the digits, those TET spells. How do we treat them? We flex the knees forward and upward, right? And then severe irritability related to those low oxygen levels. Most often, this is diagnosed in the first few weeks due to a loud murmur and cyanosis. Usually, the ductus arteriosus is patent at birth, and that's normal for a while. When it closes, though, the cyanosis is noted and more severe, and this could be a few days until that is fully seen. They'll also display TET spells and be more irritable and less in response, and then they'll become more sleepy or unresponsive if this continues. How do we diagnose tetralogy of Fallot? So you'll see that cyanosis. Oxygen will not have very much effect on the cyanosis, so it's not going to help it. You'll hear a heart murmur that is very loud, and then when the echocardiogram is completed, you will see all 4 of those deficits that are characteristic of tetralogy. This is just a video about Jimmy Kimmel's story, if you're interested in watching that. How do we treat tetralogy of Fallot? So, if the oxygen levels are extremely low, prostaglandins may be administered via IV to keep the patent ductus arteriosus open. A complete repair is done when the infant's about 6 months of age, and then some correction that's involved is a closure of that ventricle septal deficit with a dicron patch. The narrowed pulmonary valve is enlarged. The coronary arteries are repaired, and that hypertrophy of the right heart should remodel within a few months when the pressure in the right side of the heart is reduced. All right, check out this question. The nurse has admitted a child with a cyanotic heart deficit. Which initial lab result would the nurse expect to find? that high hemoglobin, right? Because they're not getting enough oxygen, so the body's producing more hemoglobin to carry what oxygen is already in the body. Now let's talk about obstructive heart deficits. What is an obstructive deficit? It's an anatomical stenosis, which causes an obstruction of blood flow and causes an increase in pressure on the left ventricle that decreases the cardiac output. So we have aortic stenosis, that's a narrowing of the aortic valve. We have coarculation of the aorta, that is a narrowing near the ductus arteriosus. And then we have a hypoplastic left heart syndrome. That is where the left side of the heart is underdeveloped. And an ASD or patent foramen oval allow oxygen into the blood. Some clinical manifestations that you may see with the obstructive deficits. So one is diminished pulses. So they're bounding in the upper extremities. The blood pressure will be increased in those upper extremities and decreased in the lower extremities. Poor color, delayed capillary refill, decreased urinary output, signs of congestive heart failure. What are those? Dyspnea, tachypnea, intercostal retractions, wheezing, grunting, edema, cardiomegaly, hepatomegaly, distended neck veins, and possible weight gain. What's that from? Edema. So just be on high alert. Bounding pulses and increased blood pressure in the upper extremities and weaker pulses in the lower or lower blood pressure in the lower extremities may indicate coarculation of the aorta. Let's look at some different types of obstructive deficits. The first one we are going to talk about is coarculation of the aorta, or COA. This accounts for about 7% of deficits. It's a congenital narrowing of the descending aorta, and 80% generally have aortic valve anomalies. There's a difference in the blood pressure in the arms and the legs. That indicates a severe obstruction. So you have the narrowing of the aorta, the main blood vessel that carries oxygen-rich blood from the left ventricle to all of the organs in the body, right? So this is very common in chromosomal abnormalities like Turner syndrome. It can lead to congestive heart failure if the coarculation is severe and the ventricle cannot get blood forced through. And then what do you think happens? It backs up into the heart. Take a look at this picture. It shows what coarculation of the aorta looks like. So, how is this diagnosed and what do we do to treat it? So in 50%, the narrowing is not severe enough to cause symptoms in the first days of life. So when that patent ductus arteriosus closes, a higher resistance develops and heart failure can develop. So, more seen after or found after that PDA closes. The pulses in the groin and legs will be diminished, and an echocardiogram is going to show that deficit in or that defect in the aorta. So depending on the severity of the coarculation, it may not cause any symptoms until after the first few days of life when the ductus arteriosus closes. Once that closes, it'll cause higher resistance that the heart must work harder and lead to congestive heart failure. It can go undetected for years. When there's a heart murmur or high blood pressure, especially, it may be noted when the pulses are difficult to feel in lower extremities versus the upper extremities. All right, so how do we treat this? We have the prostaglandin that can be given to the patent ductus arteriosus to reduce those, to open it and reduce the pressure changes. But the most common repair is resection of the narrowed area with anastomosis of the two ends. So surgery is generally done for critically ill newborns, but in older children, if the symptoms are minimal, it may be an elective surgery. So keep in mind when this happens, there's some surgical complications. So there can be kidney damage due to clamping off of the blood flow during the surgery, and then high blood pressure can happen post-op. So they may need antihypertensives. And then also they will need some antibiotics prophylactically. Okay, you can pause this, read the question, and then we will resume. A child is being admitted with a possible coagulation of the aorta. The admitting nurse reviews the medical orders for the child and should question which of the following orders. I would question D. The correct answer is D. Vital signs on admission and daily. I think you'd want to do them just a little more than that, right? All right. Mixed heart deficits. Any mixed heart deficit is going to be a combination of deficits that increase and decrease pulmonary blood flow, making the newborn dependent on mixing of pulmonary and systemic circulation for survival. Some examples of this are transposition of the great arteries and trunctus arteriosus. With these mixed deficits, clinical manifestations that you will see are cyanosis, poor weight gain, tachypnea, dyspnea, and congestive heart failure. Again, what's congestive heart failure look like? A multitude of symptoms such as dyspnea, tachypnea, intercostal retractions, wheezing, grunting, edema, cardiomegaly, hepatomegaly, distended neck veins, possible weight gain. What's the possible weight gain from? Edema. So what are we going to look at? We're going to look at several diagnostic tests, such as chest x-rays, ECGs, echocardiograms. We're going to get the hemoglobin and hematocrit levels. Why? Use your critical thinking skills, ABGs, and interventional catheterization may be used. Let's move on and talk about some types of mixed heart deficits. First, we are going to talk about transposition of the great vessels. This is when the arteries, the aorta, is connected to the right ventricle instead of the left ventricle, and the pulmonary artery is connected to the left ventricle instead of the right. There's a septal deficit or a patent ductus arteriosus, and those must exist in order to oxygenate the blood, right? If you don't have a way to get the oxygen in there, the person will not survive. All right, here's the diagram. Take a look at that. What type of treatment is seen for transposition of the great vessels? It obviously has to be corrected, right? So that's done by an arterial switch operation. That is going to correct the transposition and by moving the pulmonary artery and the aorta to their correct positions. Also, they will be given IV prostaglandin infusion to keep that patent ductus arteriosus. What is truncus arteriosus? It is the failure of the septum formation, resulting in a single vessel that comes off of the ventricles. And you can see that in the following slide. So, what does this look like? How do we treat it? So, infants with truncus arteriosus or other conditions causing cyanosis can have symptoms such as problems breathing, pounding heart, weak pulse, ashen or bluish skin color. Why? Not getting oxygen, right? Poor feeding, again, don't have any oxygen for energy, and extreme sleepiness. So treatment for that is going to be diuretics to treat that congestive heart failure and surgery. They're going to have to rebuild the heart, and they will need follow-up surgeries because why? Children are still growing. So those follow-up surgeries will need to happen as the child grows. So the heart grows with the child, so surgeries are going to be needed. Some generalized treatment that we're going to talk about up next. Now let's talk a little bit about just some generalized treatment pertaining to pediatric patients who have cardiac dysfunctions, whether it be treatment or diagnosis procedures. We're just going to look a little more in depth at some of those things, specifically pertaining to children. All right, so we have conservative treatment and then ibuprofen or indomethacin to close that PDA. What is a PDA? That's that patent ductus arteriosus where that's open. And then prostaglandin E to maintain PDAs, cardiac catheterizations, and surgery. All right, let's talk a little bit about cardiac catheterization. So pre-procedure, you want to make sure that you're assessing vitals, assessing for allergic and any allergies to iodine, assessing and marking the bilateral pedal pulses, and educating the child and family. So keep in mind, there's a risk for hemorrhage from the entry point, clot formation, or dysrhythmias. So they have to be in PO for at least 4 to 6 hours prior to this procedure. After the cardiac catheterization, you're going to want to make sure that you apply pressure to that puncture site, assess the dressing every 5 to 15 minutes for the first hour, and protect the dressing from any fecal and urine contaminant. You want to keep the extremity straight for 4 to 6 hours. They need to lay flat for at least 2 hours. Assess the pedal pulses distal to the puncture site and compare with those on the opposite extremity. How should those be? Those should be equal, right? You want to assess the temperature, the color of the affected extremity to the distal to the puncture site. So what would coolness indicate? An obstruction, right? That's why we're assessing that site. We want to make sure there's no clot formation. And then you want to be assessing for pain, monitoring their I&O, and just keep in mind, there may be some dire contrast involved there. So you want to monitor the oxygen. They'll be on a cardiac monitor for at least 4 hours afterwards. So what are some risks after the procedure? You have hemorrhage, hematoma, vasospasms, a decrease in those pulses in the affected leg, and dysrhythmias. So generally, those kids go home, right? So we want to talk about discharge teaching. You want to teach the parents or the caregivers to remove the dressing on the day after the procedure and cover it with a Band-Aid for 2 to 3 days. They want to keep the site clean and dry and avoid any tub baths for 2 to 3 days. Observe for signs of infection. So you may have to teach some signs and symptoms of infection, provide a diet as tolerated, administer pain medication as needed, and definitely keep those follow-up appointments. All right, so let's look at your critical thinking skills a little bit. So John has just returned from his cardiac cath and arrives to the pediatric unit. He's still drowsy and has a pressure dressing on his right groin area. What nursing assessment and interventions will you complete? All right, so you want to make sure that you are assessing the right groin dressing, getting those pedal pulses, vital signs every 5 to 15 minutes for the first hour, right? You want them to remain flat for 2 hours. That way they get that good circulation, and then monitoring that I&O for that contrast dye. So you want to be looking for that. So those are some very important things for you to remember. Let's talk about congestive heart failure. What is that? That's failure of the heart to effectively circulate the blood as a result of left or right-sided heart failure. So some manifestations of that are impaired myocardial function. So sweating, tachycardia, fatigue, pallor, cool extremities, weak pulses, hypotension, and cardiomegaly. Pulmonary congestion is another manifestation. So you would see tachypnea, dyspnea, retractions, nasal flaring, grunting, wheezing, cyanosis, cough, orthopnea, and exercise intolerance. Also, you can see some systemic venous congestion. So with that, you'll see hepatomegaly, peripheral edema, ascites, neck vein distensions, periorbital edema, and weight gain. So with right-sided heart failure, ascites, hepatomegaly, jugular vein distension, oliguria, peripheral edema, and periorbital edema and weight gain are seen. So remember, with left-sided heart failure, you'll have those crackles, wheezes, cough, dyspnea, grunting, nasal flaring, orthopnea, periods of cyanosis, and that's from the fluid in the lungs, retractions, and tachypnea. Moving on to interventions with congestive heart failure. What are some interventions you're going to be doing as the nurse? Monitoring that respiratory distress. They're going to be on a strict I&O, monitoring daily weights, monitoring edema, maintaining a neutral thermal environment, and organizing nursing activities so that there's uninterrupted sleep, and then monitoring those serum potassium levels, right? More interventions are going to be fluid restriction, diuretics like your Lasix, and remember those are potassium wasting, so we're looking at those potassium levels, or aldactone, which is potassium sparing, so again, looking at those potassium levels, and then administering digoxin, bed rest, oxygen, small frequent feedings, so you can use a soft nipple with supplemental NG for adequate calorie intake. They're going to have a pulse ox measuring their oxygen levels, and they may even need sedatives. Food and nutrition is extremely important in children, right? This is a time when they're growing and it happens really fast, so they need adequate calories and nutrition. So with these cardiac patients, small frequent feedings, soft nipples to easily conserve that energy that's needed to suck, 24-calorie formula for additional calories is often seen. That's important for you to know, increasing those calories using that high calorie formula, and then also using NG tubes for feedings if they aren't taking adequate calories to gain weight. Why? Because they get really tired. It's hard for them. A lot of these cardiac patients may be receiving digoxin therapy. So remember back from pharmacology and your med-surg courses that digoxin increases the force of the myocardial contraction. However, it does decrease their heart rate. So it decreases the heart rate, increases the force. So you want to make sure that you're taking the apical pulse with a stethoscope for 1 full minute before you give the digoxin. If you suspect bradycardia or their heart rate is too low, you want to make sure that you call the physician before administering the drug. So it needs to be above 100 beats per minute for an infant and a toddler to give digoxin. It needs to be above 80 in the older child and above 60 in the adolescent. Remember, digoxin can be too high, right? So do you remember what some of those signs of digoxin toxicity is? Bradycardia, arrhythmias, nausea, vomiting, anorexia, dizziness, headache, weight weakness, and fatigue. So what is that normal digoxin level? Do you remember? It's 0.5 to 2 milligrams per milliliters. That's important for you to know. All right, take a look at this question. A nurse is caring for a ped patient who has congestive heart failure. The client is receiving digoxin therapy. Which lab result is most important to evaluate when preparing to administer digoxin? The answer is A, potassium levels. Serum potassium levels that are too low can cause that digoxin toxicity. All right, let's do a little review and test your critical thinking skills. So you have a child who's diagnosed with congestive heart failure. They've been prescribed digoxin. What nursing considerations should be taken when administering digoxin? What instructions should be given to the parents regarding the administration of digoxin? You want to make sure that you're counting the apical pulse for a minute prior to administration, right? And monitoring those potassium levels, because if the potassium's too low, that can cause them to become at a toxic level as far as their digoxin levels. So, teaching them signs and symptoms of digoxin toxicity, how to take that apical pulse, what to do if it is too low, and also when to contact the physician in general. So that concludes this lecture. Make sure that you go and watch the rest of the cardiac lectures because we're not quite done.